Welcome to a neuroanatomy part 2, video 2. We're going to talk about anatomy of the brainstem, specifically the cranial nerves of the brain. We have 12 of them, and it can seem a little overwhelming to try to learn all 12. So I'm going to break it down. I'm going to go through each cranial nerve separately, and then at the end teach you a couple strategies to help group them based on function, and hopefully it'll help reduce the load a little bit and help consolidate it. This information you will definitely need this when you go into neuro, so do learn it. I am giving you these mnemonics, and those are handy in a pinch. But if you learn the material, it'll really carry over to neuro, and as an undergrad, and then into graduate school when you're taking your neuro courses. So our cranial nerves, specifically for speech therapy, are so important um, to our field. So when you get a patient, you should have a good idea of what cranial nerves are affected. Um, it's important. So I have two different mnemonics, and I'm sure you guys have heard of a couple. If you've taken anatomy before, you can even Google some. But the first one is uh, so just to help you with the names of the cranial nerves, and it's on occasion our trusty truck acts funny. Very good vehicle anyhow. So you can write that down on your test or quiz, or test actually, um, to remember the name. And then the function, we have either um, you can either have a motor cranial nerve, a sensory cranial nerve, or a cranial nerve that does both. So, and there's 12, so it's lined up in this. This is cranial nerve 1, this is cranial nerve 1, this is cranial nerve 2, this is cranial nerve 2. So the mnemonic for the function is, some say Mary Money, but my brother says big brains matter more. All right, so let's talk about olfactory nerve, which is cranial nerve 1. And if you think back to our cranial skull, and when we were talking about um, the crista galli and the cribriform plate, uh, cranial nerve 1, the olfactory bulbs, actually sit right um, in that cribriform plate, which is right here. So here's the olfactory foramina. This is the mid-sagittal view, anterior, posterior, olfactory tract, olfactory bulb right here. So if you just moved a little bit more medial, you'd be able to see the crista galli. So this nerve actually tells you what it does. It's sensory only, and it's in charge of olfaction. Remember that, smelly olfactory. So its job is to provide the sensory relay for smell, and it's the most anterior. And all of the nerves are based on their numbering is based on where they're located. So the more anterior and superior, the lower the number. All right, the next one is our optic nerve, and this tells you again what it does. So it's part of the optic tract, or optician, ophthalmologist. You've heard all those words before. So it's in charge of vision. Okay, so number 2 is vision. Here's our optic nerve. Remember the optic chiasm here. All right, so I do think this is an important slide, and so let's talk about the optic chiasm a little bit. So I'm just going to make this picture big so we can really tease out some of the important parts of it. All right, so this here is a horizontal view of the optic tract. Let's just talk about the black first. Okay, so let's start here with the left eye. And we have different fields of vision. So we have our nasal field and our temporal field. So this is our peripheral vision out here. And there's a lot of decussation, or crossing over, that occurs in our visual tract. So our temporal field is picked up by our medial retina, which is right here. So our peripheral vision is picked up by our medial retina, and you'll see that, okay? So this part of the retina. Whereas our nasal field is picked up by our lateral retina, which is right here. Okay, and that's true for both eyes. So our temporal fields are picked up by our medial retinas, and our nasal fields are picked up by our lateral retinas. Okay, so let's continue talking about our left eye. So our nasal field is going to be picked up by our lateral retinas, and then that information is going to travel down, okay, and then be carried over to the left side of the brain to be processed. Okay, not a big deal. So information at the level of the left retina, left lateral retina, is going to be processed in the left side of the brain. Okay, that's a very linear ipsilateral processing. Ipsilateral meaning it doesn't cross over. Okay, so this is ipsilateral processing of the information. Same thing with this one. So left retina or right retina, the information from the right retina stays on the same side of the brain. Okay, although we're getting information from the temporal lobe, or sorry, temporal field, or that peripheral vision. Okay, or from the nasal field. Sorry. So from here, the only crossing over is happening right here. Okay, now it gets a little more interesting when we start talking about peripheral vision. So if we have information from our temporal field hitting our medial retina, traveling down the optic tract to the optic chiasm, and something really interesting occurs. That information then travels over to the other side of the brain to be processed. Okay. So our peripheral vision is processed on the other side of our brain. So there's huge crossing over like this. Okay. So that's important when we start to talk about lesions to this tract and this processing system. Okay, so if we have a lesion at the level of the left optic nerve, we're going to completely occlude any information that comes from the left eye. Okay, none of it is going to get to the brain, right, from the left eye. Okay, that's pretty straightforward. Same with this one. Now it gets trickier if we have a lesion at the level of the optic chiasm. Okay, if we have a lesion at the level of the optic chiasm, we're not going to be able to process information that peripheral field information, because all of that information needs to cross over to the other side. That medial retina, the information that's the temporal or peripheral vision, is not going to get over to the other side of the brain. So we're not going to have peripheral vision if we have a lesion here. Now, if we have a lesion just posterior to the optic chiasm here, we're not going to have peripheral vision in the right eye, okay, and we're not going to have our nasal field any longer in the left eye. So if you can draw this picture, and I recommend that you try to, when you get to an exam, if I say if we have a lesion here, where are you going to have a visual field deficit? You'll be able to answer that. But drawing out this map is super important, because if you walk through this picture and make these lesions on your own and think through where the crossing over occurs, you should be able to answer that question just fine. And here's a picture, a key, if you want to look at it. However, it's much easier to kind of walk through the process of it rather than memorize it, because there's 2 points of decussation and it gets confusing really quick. Okay, but what a cool system, right? All right, so let's go on and talk about the ocular motor. So there are really 3 nerves that are responsible for movement of the eye. Now they do move different muscles of the eye, but since we didn't learn about those muscles, we're not going to get into it. You just need to know that it's motor to the eye. It helps move the eye. So one is ocular motor. There's a couple more coming up. We're going to go through these stepwise in terms of numbering, and then we'll group them, okay? All right, so then the second one is trochlear. So ocular motor, trochlear, and I have an acronym. I use ODA to remember it. Abducens is the last one. Okay, but now we're gonna go to trigeminal and talk about that, and then we'll move to so here's abducens. So you'll see that we have eye movement, eye movement, eye movement. Okay, so 3 just for eye movement. OTA, O-T-A, for eye movement. Okay, and then we have optics. So there are actually 4 different cranial nerves just responsible for eye movement, which is a third of all of the cranial nerves that you need to learn. All right, so let's talk about trigeminal. This is one of my favorite cranial nerves. It has both sensory and motor components. So let's talk about the sensory piece first, because that's the most interesting to me. It has 3 branches. So it has the maxillary, mandibular, and ophthalmic branches. So ophthalmic, maxillary, and mandibular. And so I think of that as the tri part in trigeminal. And then Gemini means twins. So I think of 2 and 3 equals 5. And so that's how I get to the 5th cranial nerve. So it's sensory to the face and motor to muscles of mastication, such as the masseter. Okay. It also plays a role in innervation to the tongue, and we'll get to that in just a minute. All right, so there's our abducens, eye movement. All right, so then the facial nerve. This is an interesting one. If you work with adults, this will come into play. So the facial nerve is responsible for both sensory and motor function. So muscles, it innervates muscles of the face and is also responsible for taste to the anterior 2/3 of the tongue. So we're going to do a little practice with the tongue, in terms of how it's innervated, and so that'll come together in a little bit. But I do want to talk about innervation to the face. So, okay, so here is a picture of the facial nerve. So there is a right and a left cortical innervation, and then it travels down to the brainstem here, and then sneaks out to the face. Okay. So all of our cranial nerves, except for part of the facial nerve and the hypoglossal nerve, have both sides of the brain telling it to work. Okay, and there's this crossing over that happens. Just like the optic chiasm has crossing over, so do all of our facial nerves, except for the hypoglossal and then the lower part of the facial nerve, which is this guy here. So let's look at this. So if we look at the orange one here in the left hemisphere, so we have motor information, and it's actually traveling through via that corona radiata, those projection fibers, via the motor strip. So here's the motor strip in the frontal lobe, and it's sending information down through the corona radiata. This is the internal capsule here. Okay, and then there's an interesting point of decussation, of crossing over. Now information is going to go to both facial nerves, okay, here and here, and that facial nerve is going to branch off into 2 primary facial branches, okay, and they're going to both branches are going to travel down together until they get to here. Then they're going to branch off separate. Now, only the superior facial nerve branch is going to have information that's crossed over, that has decussated from one side to the other. Okay, and that's important in just from a pathophysiology perspective, and we'll get to that in just a second. Okay, so we have information from both sides of the brain telling the facial muscles up here to work. However, our lower facial muscles, orbicularis oris, risorius, levator labii superioris, mentalis, all of those muscles are not being innervated by both sides of the brain. Only the muscles, this is the right side of the face. All of those muscles are being innervated or told to work by the left side of the brain. Okay, so let's talk about it from a pathophysiological perspective. If we have a lesion here, okay, that's a big deal in terms of making the lower part of the brain, of the facial muscles, work, right? So if we have a lesion in the left part of our brain responsible for motor control of the facial nerve, we're going to have paralysis of all of these muscles down here. Okay. However, we may only have weakness, if nothing, up in the superior muscles of the face. Okay. And the answer lies in this decussation, this crossing over. So the facial muscles on the upper third of the face are also innervated by the right hemisphere as well. Okay, so that hemisphere is intact, right? whereas this part is no longer intact. So that information is still going to be traveling down this superior branch, right? Telling these facial muscles to work. Now you may see some weakness, we call it paresis, but you're not going to see that paralysis like you are in the lower side of the face. So if you have a patient that's had a stroke in this part of the brain, you are going to see some right facial droop, specifically around the mouth, but you're not going to see a lot of that around the eye, for example. Okay? So super cool. So here's another picture of it just to give you a better view. Now the hypoglossal is that other nerve that's not bilaterally innervated. So all cranial nerves have this crossing over, this decussation, except for those two, facial nerve and hypoglossal. Now hypoglossal has no point of decussation, whereas the facial nerve does have, a third to half of it does have some decussation, right? Okay. All right, now we get to move to the vestibular cochlear. That's responsible, and it tells you what it does. It says, I'm responsible for balance, this vestibular function, and for hearing, the cochlear. Remember, the cochlea is responsible for hearing. So I do balance and hearing. Okay, so that is a sensory only nerve, so cranial nerve 8. All right, so cranial nerve 9, and you do need to know the numbers. So, and that's where the mnemonic comes into play. And you need to know the numbers, not because I want you to be amazing memorizers, but when you're in other courses, you're going to be asked to be able to answer questions based on the numbers system. Now, on your guys' test, I'm not gonna, if I give you the facial nerve, I'm not going to give you just the number. I may give you the name and the number. But I do want you to start being able to order them based on number, because especially if you take your anatomy from Professor Slovart, she likes to talk about her cranial nerves based on the number. So cranial nerve 7, cranial nerve 9, and so forth. So you will be lost if you don't know them by their number. So you start to be familiar with it now, so that you're not having to learn it then. Because that's not the meat of her presentation for the most part, is learning those. This is, you learn it here. All right. So the next one we get to talk about is glossopharyngeal, and it's responsible for both taste and then somatic sense of the tongue and the pharynx. Okay, and then it innervates the muscles of the pharynx as well. Okay, and you don't need to know which one specifically. All right, so here's a picture of the glossopharyngeal. And we're going to get into it when we talk about the tongue as well. All right, the vagus is a cool one. So the vagus, my professor, when I was learning anatomy, told me that the vagus can go anywhere and do anything, just like when you're in Las Vegas, Nevada. So the vagus can go anywhere and do anything. So it does autonomic and somatic functions. It's huge. It plays a huge role. You'll learn about the 3 branches when you get to neuro. In terms of our scope of practice. So just know that it has autonomic and somatic innervation. It does everything. We're not going to get. And so here's a picture of all the things that it does. You don't need to memorize all of this. Just remember somatic and autonomic. All right, so the 11th cranial nerve is our accessory. It innervates 2 primary muscles that we're interested in, and that's sternocleidomastoid and trapezius. Okay. And they're just these little guys here. Okay, so there's accessory, sternocleidomastoid, and trapezius. All right, and then hypoglossal cranial nerve 12 is our last one. Innervates muscles of the tongue except for palatal-glottis. Okay, and so it's all motor. Remember, that one is not bilaterally innervated. I do want you to know which ones are bilaterally innervated and which ones aren't, because that's important from a pathophysiological perspective. If you have a patient that's had a stroke, you're say they have right hemiparesis, which means they have paralysis or weakness on the right side. They've had a stroke, most likely on the left side of their brain, and the right side of their tongue is not going to work. That's important in terms of articulation and motor planning and so forth when you're working with a patient on their speech. All right, so here's the hypoglossal nerve. So just motor to all of the muscles of the tongue, except for palatal. All right, so now I put together a little slide for you. This is just in the video, and breaking it down to help categorize it by function. So there are four cranial nerves to the eye, optic for sensory right vision, and then we have oda, okay, oculomotor, trochlear, and abducens. Then we have one for smell, olfactory, one for hearing and balance, vestibular cochlear. It tells you exactly what it does. Then we have three for the tongue, and we're going to go this on the next couple pages. We're going to talk about that. And then we have two more, one that are responsible for innervating the face. So we have the facial, and then we have trigeminal. So trigeminal is sensory to the face, and actually somatic sensory to the tongue as well. And then we have taste in terms of the facial muscle, and then the facial nerve, and then we have facial that's responsible for innervating motor for the facial muscles. And then vagus vagus does everything autonomic and somatic functioning, and then accessory sternocleidomastoid and trapezius. So 12 total. So I hope that helps break things up for you guys a little bit in terms of functionality of each of the cranial nerves. Do remember that you need to know the number as well, so you can use the mnemonic for that. But in terms of actually learning it instead of trying to memorize it, this slide should help you guys. All right, so let's talk about the tongue a little bit. I actually, on the next slide, I made another picture, and I want you to try to do that on your own. I'm not going to ask you to turn it in, but I do want you to try to do it on your own to help you study. So here's a superior view of a tongue. Here's the tip. Okay, so on the left here, we're going to be talking about motor function. Okay, and on the right here, the right part of the picture, this is actually the right side of the tongue, right? But on the right side of the picture, we're going to be talking about sensory. Okay, so glossopharyngeal is responsible for this posterior 1/3 of the tongue in terms of general sense and taste. Okay, whereas the anterior 2/3 of the tongue, we have trigeminal, responsible for general sense. So if you go to the dentist and they numb the lower left half of your mouth, you're not going to be able to feel your tongue either, and that's because they're numbing trigeminal. And then we have taste for the anterior 2/3 of the tongue, which is the facial nerve. Okay, so here's a picture. You should be able to draw this picture when you're studying to test yourself. So again, this is motor, this is sensory, and this is just my tongue. So here's the tip of the tongue. So hypoglossal, remember, it's unilaterally innervated, which means only one side of the brain controls it. Okay, and then and it is, although there is decussation, so although only one side of the brain innervates it, the right side of the tongue is innervated by the left side of the brain. All right, so then we have glossopharyngeal, responsible for taste and touch for the posterior aspect. Then we have facial and trigeminal, responsible for the anterior 2/3 of the tongue, whereas facial is responsible for taste and trigeminal is responsible for touch. Okay, so if you can draw out this picture, you'll be able to understand all of those nerves a lot better. All right, and then this is just one more picture to help bring things together for you if you're a visual learner. So you can print this slide out just as one big slide and practice that way as well. All right, well, congratulations, you guys. We have just finished the last part of chapter 11, which is a really big chapter. So I hope you guys enjoyed it. I hope you're excited about neuro and that you cannot wait to get to your neuroanatomy class and neurophysiology class. You get a whole course on it. So it's just a ball, and it's a huge part of our field. So I suspect that some of you might have wanted to go into this field because of neuro. I did. I thought, oh my gosh, I want to learn more and more about the brain and how it works and how it relates to me as a clinician. And so what a cool field, because this is a big, we kind of get the head up, perspective. So anyway, I hope you enjoy it. I hope it's just, kind of, I don't know, inspired you to want to learn more. All right. Have a good day, you guys.